My name is Dr Rageshri Dhairyawan and I'm a doctor, researcher, student and advocate. I currently work as a consultant physician in sexual health and HIV medicine at Barts Health NHS Trust in East London. My day-to-day job includes HIV clinics and inpatient work. In this video, you'll hear me talk about what I call the medical practice of silencing, how societal bias can affect who gets to speak up and who gets heard in healthcare and research, how I found my voice and how I try to use it to help raise the voice of others. I'll take you through my career journey from my childhood in Essex as an immigrant from India and what inspired me to pursue a career in sexual health. I'll talk about the research I've been involved in, the challenges I've encountered and the importance of the patient community in leading research to make impactful change. I'll also be sharing my personal experience of being a patient, what it's taught me and how it drives my activism and advocacy today. For me, the role of being a doctor and improving patients' health extends outside the consultation room, so I'll discuss how I've tried to do this. I'll also tell you what I've learned about staying engaged in social justice work in a healthy and balanced way. So I was born in India and moved with my family to Essex when I was 2, and both my parents are in healthcare, so I think probably quite common in Indian families. My mum is a GP and my dad is a dentist. And for me, I think they were really great role models. I saw them working really hard and I almost feel like I grew up in the NHS. So my sister and I, after school, they would pick us up and then they would take us to their surgeries and we would do our homework there until it was dinner time and they finished work. So I felt like, you know, the NHS was where I grew up. It was almost like my nursery in a way. And my mum particularly, I think, has really inspired me. So she always wanted to be an obstetrician and gynecologist. But due to various reasons, and I think particularly what was happening at the time in the 70s in terms of sexism in the NHS and racism, she was told she could never be a consultant. So she went into general practice, but managed to specialise in family planning. So I always thought she was incredibly inspiring to keep learning while being a GP, and she pretty much ran the family planning practice in the town where I lived. So I think that probably helped me decide to go into sexual health, and I've been particularly interested in kind of women's reproductive rights, and as I've done sexual health, more about thinking about minoritised populations and stigma in general. I think I've always found it interesting, but I never really had kind of any plans to go into academia. I didn't think about doing a master's or a PhD when I was training in sexual health. But I do remember going to a conference with some colleagues at the hospital I was working in, and we watched this amazing speaker give a talk about sexual health and sexual violence and the links between the two, which I had never heard of and neither had my colleagues. And we were sitting there saying, this is such a common thing. So we know that sexual violence can be a risk factor for getting things like HIV and other sexually transmitted infections. So we kind of sat in this really interesting session, took the idea back to our clinic and thought, why don't we do something about this? Like, no one has looked at this topic in the UK, although there's lots of evidence around the world. So we ended up doing a project looking at intimate partner violence. And looking to see how common it was amongst the women living with HIV who attended our clinic. So this was in East London, so it all felt very organic. It came from something we were very interested in, and we thought this would be useful for our patient population if we know about their experiences to make sure we have the right services for them. So we did the research. And we actually found that half of the women who attended our HIV clinic had experienced some kind of intimate partner violence, which is twice what is the average in the general population, where it's 1 in 4 women. It's the first time this kind of research had been done in the UK. And as I said, it's a link that's really well known globally. So it felt very impactful to do the research. And I remember presenting it at a national conference and there were women living with HIV in the front row. And I finished the presentation and they came up to me and said, well, you know, we're really happy that you and your colleagues have done this because this is showing what we know happens, but no one has ever produced the evidence. So that for me was a big thing to do something that felt impactful. But it also led on to me doing other work around domestic abuse and sexual health. So we managed to get some guidelines about screening for domestic violence in sexual health nationally, and our research ended up being cited in 3 national guidelines. So that felt amazing, but it was really challenging. My experience of being a patient has been one of the most pivotal points in my career, and it's massively changed my approach to everything I do in medicine, including practicing as a doctor. So I was diagnosed with endometriosis, which is a very common menstrual condition. It affects about 1 in 10 people who menstruate, and commonly presents with pain. And I was having some treatment more than 10 years ago now, but I ended up being in a lot of pain and taken to A&E by my husband and was admitted for pain relief. So I was on the ward, and they knew that I was a consultant, and it was a hospital that I knew fairly well. So they put me in a side room, I think, because they felt I was a colleague. So that was a good, it was a nice thing for them to do, to give me some privacy. But as my stay went on, I noticed that every time I asked for pain relief, I was told to wait, and I was really made to feel like asking for more pain relief wasn't because I needed it. It was because I was a nuisance, and perhaps because I just wanted to have opiate medication, so it wasn't a genuine need. So I felt really dismissed, and it was quite a scary experience being stuck in a side room on a ward, unable to get the pain relief I needed. And it really got me thinking that if this can happen to me, and I just become a consultant, so I knew how to navigate the NHS very well, I knew what to say. If that could happen to me, what happens to all the other patients who don't know how to navigate the NHS, who may not have good enough English, for example, who may not know what to say, and also people who perhaps may experience bias because of their gender or because of their mental health or their ethnicity, who may be less likely to be believed. So that had a big impact on me, first of all, just in terms of my medical practice. I always try to make sure my patients aren't in pain when I'm on the ward. It's really important that we listen to them and try to address their symptoms. But at the time, for me, I didn't feel brave enough to complain after I left, and that really annoyed me, that I didn't feel like I could speak up and make a complaint about my experience. I felt quite ashamed of what happened. And I think over the years, I started to talk about it. I started to write about it, and I include it in a lot of my teaching about bias and patient experience. And I kind of feel this is now my advocacy, is to try and advocate for more people than just myself, if that makes sense, for patient experience in general. And I think we hear it all the time. So with endometriosis, for example, it takes on average 8 years for a diagnosis in this country. And people often say they've been to their doctor and been told their pain is normal, or it's all in their heads. So that's, as I said, it's an experience that has really shaped me in my approach. And it's got me thinking a lot about bias in clinical care. I think I was just very shocked that it had happened to me, and I was lucky. My husband advocated for me. I had some colleagues I knew who worked at the hospital who advocated for me. So, I was in many ways very lucky. But I think it happens to a lot of patients, and this is something I talk about quite a lot. It's a term from philosophy called testimonial injustice, and it's essentially about giving testimony and being heard. And some people, because of their gender, again, their ethnicity, their social identity, they are not heard when they speak, when they give testimony. So they're not seen as being very credible. They're not believed, or they're dismissed. And I think this happens a lot in patient care. We take some people less seriously than others. And I think particularly for people who go back to their doctor and they continually have their kind of symptoms dismissed, they stop going, and they stop telling doctors and other healthcare workers what's really going on. And I think in that way we can really censor patients from speaking up. So that's why I call it kind of, it's the medical practice of silencing. But I think it can happen in the workforce as well. So, if people aren't listened to when they try to give their opinions in meetings, for example, they're less likely to try again, less likely to apply for leadership positions. It's an interesting one. I think, as I said, bias it does often centre around gender and ethnicity. So for women in particular, there's all these myths about women being hysterical and all of our symptoms being in our head, and that, there's a whole massive history on that. So I think that does impact, particularly when it comes to pain, but other chronic conditions as well for women, and particularly women of colour. So I think that has had, a big impact. And it really, if it's whole kind of populations of people who experience bias, so for example, women, it means that the conditions that predominantly affect them, like endometriosis, they don't get the attention they need in terms of funding for research, for policy. I remember sitting in a research conference about endometriosis, and it was for patients, and I went with a kind of very open mind as a patient, thinking, I don't actually know much about endometriosis, so let me find out. And I sat there absolutely furious all day, because we don't know much about endometriosis. It feels like, compared to other diseases, the research hasn't been done. They still don't know how to classify it, how to, what causes it, what treats it effectively. So for me, it's a condition that mainly affects people who aren't listened to or are told that it's all in their heads, and because of that, we're very behind on knowing how to treat it. It's really hard because I'm very, very shy. So when I was a child, when we moved from India, I didn't speak English till I pretty much went to school, and I do remember I always was told at school I was very shy and should raise my voice. And then we'd go back to India for the summer holidays, and I'd come back and the teachers would say to me, "Oh, you've come back with an Indian accent, like you mustn't." So that would keep me even more quiet. But I think it's become louder as I've become a more senior doctor. I think working with the patient population that I do, who are very heavily stigmatised for lots of reasons, be it having HIV or to do with their kind of social status. Sometimes they can't speak up for themselves, and you end up having to firstly speak up for them, but with the aim of actually helping them to speak up for themselves. So I think some of the injustice that I've seen that my patients have experienced has helped me speak up, and then that's led to kind of teaching and me talking a lot more. But I'm still very shy. I mean, in meetings, I still don't speak up that much. So it's been an interesting journey. So I don't think shyness is a bad thing. And I think perhaps we often talk about leadership, particularly in the NHS, about speaking up and being assertive. But I think one of the things that we don't do enough of is actually listening when we're in leadership positions, and instead thinking, oh, I'm chairing this meeting. Have I let everyone have a chance to speak and acknowledge what they've said? I think if we did more of that, again, it would bring up some new perspectives. I think it's really important to acknowledge that patients have got lived experience of their bodies, their health and their illnesses. So actually they are experts. And as healthcare professionals, we have expertise as well. But it's important to have both types of expertise. So when we're talking to patients, acknowledging that they know what they're talking about, but they often will need help from us as well. For example, it's quite common when we hear patients say, oh, they've spoken to a doctor, but they didn't feel that they got the response they wanted, to say to them, well, next time go back and just be more assertive. But actually it's harder for some people to be assertive, and because of stereotypes, they may come across as seeming aggressive. So we know, for example, particularly like women of colour, black women are often stereotyped as being seen as angry black women. So if we're telling people to be more assertive so they can be heard, that's actually doing them harm. So I think that's something that we need to deal with as healthcare professionals, that some of our patients aren't being listened to. It's up to us to do that active listening. It's not up to them to be more assertive. The patient group I work with often need to advocate for themselves, so trying to advocate for some of their needs as well. I don't think you can do that work without doing some advocacy and speaking up. And particularly in sexual health, it's a specialty where people aren't loud about their sexual health problems. And again, HIV is so stigmatized, but it does need more attention. It needs us to talk up about it. And the more we talk up about sexual health issues, the more we challenge taboos, and that improves patient outcome in the long term. And for me, I think being a doctor is not just about the in the room consultation, what you can do to help your patient there. It's about thinking about their living circumstances. So when we think about, for example, the social determinants of health, we know they probably affect people's health more than their behaviours. So I always think, most of my patients' health is determined before they come to see me, before they reach the hospital. So what can we do to improve their lives? What can we do to advocate for them? So, for example, thinking about, migrants who aren't able to access some NHS care, what can we do to advocate for them to access the care they need? So for me, anyway, I feel my role is about more than just the individual patient. It's about advocating for groups of them who don't get the access or the care that they need. So I think I use social media as a professional. I have to say that's been something that's been very useful for me. I think social media has lots of downs as well as ups to it. So I think it's about using it in a way that's professional, but I think it's a really great way to network with other like-minded people or people from different specialties. But you can also talk about things that happen in your specialties. So you can, advertise things about sexual health or educational stuff so other people understand a bit more about it. So for me, I think that's been really important. And one of my roles over the years has been to lead on the external relations for the British HIV Association. So we used to do a lot of stigma campaigns to challenge HIV stigma, particularly around World AIDS Day. And, doing that felt like a really kind of useful public information campaign to do. So that's one way I think in which I do that. And also trying to just help people in medicine realise that sexual health is a specialty and we're quite important. Actually people's sexual health is very important to them. When things go wrong, it can go very wrong and it can have huge impacts on their lives. So trying to challenge those taboos is really important. So probably, I think for the last 8 or 9 years now, I've been part of the medical advisory board for a charity called NAS, which is based in London, and it's for ethnic minorities around sexual health. I think different cultures have different attitudes to talking about sex and sexual health, and also there may be different stigmas in terms of people's sexuality. So it's been great working, for example, with NAS or similar charities like that to really do some public health campaigns. So something we do a lot of is trying to encourage people to have HIV tests and, just trying to normalise sexual health a bit. So I think we're seeing, for example, in the past, some communities, there's been a lot of stigma talking about mental health. And I think there's perhaps been a bit of improvement in that. So thinking particularly about my community, so the Asian community, I think we're slightly better about talking about mental health, but I think the next step is sexual health. And I think the reason it's really important I see it in my clinic, so in my HIV clinic, I will often see married couples. The man has probably got his HIV from having sex with other men, but because of the society he's in, he's married to a woman and he's never been able to live in the perhaps sexuality he's wanted to, and she's married him not knowing that about him. And you just think, it's a sad situation. Perhaps if we were more accepting of people's sexualities and letting people live in the life they want to, then people would have better sexual health outcomes. So I think it's something that's not talked about a lot. So I think any kind of raising awareness we can do, and thinking particularly about Asians. So we've just set up a new CIC, particularly around South Asians and HIV, is to just get the message out there that it does affect people from the Asian community. It's not very common, but it does affect us. So people should think about, testing for HIV and other STIs as part of their normal health checkups and trying to normalise things. I think it's just taken a very long time, and I've spoken to it with some colleagues who've actually had similar experiences as well, in different ways, and it's often women and it's often reproductive health or gynecological health that's been the issue. And I think, it's interesting, isn't it? I'm not sure. I think part of it was my shame at not complaining at the time, and I have a colleague who had a bad experience in a hospital, and she complained and she changed the practice, and I remember thinking, that's incredible, and I wish I had been brave enough to do that. So I think it's partly just talking to more and more people, but actually the piece that you mentioned in the Lancet, where I write about my experience, I was really glad to get it out there, but I felt very overwhelmed afterwards because I got contacted by a lot of people who've had similar poor experiences. And I felt like, gosh, I don't want to speak for all these people, but it shows how common it is. But it did feel quite overwhelming. So I think, the more I speak about it, it's just being aware of how it can affect me as well. And actually, I was asked to go on national radio to speak about it, and I actually declined in the end, just because I thought it wasn't the right time for me. So maybe in the future, that's something I would do. But it's all a journey, so I'm still getting there. So I think it's really made me think about power imbalances. I think, however we may feel that we make things very comfortable for our patients, there is always a slight power imbalance there. And with some patients, it may be bigger than we realise. So being aware of that, trying to do as much as I can in terms of body language, in terms of language, to make them feel comfortable. Active listening, so hearing what they're saying and also validating what they're saying. So the whole kind of, I hear you, what you're saying, and I'm very sorry that this has happened to you. I think all those things can help us encourage patients to talk to us. And I think if we don't do that, then we're missing huge parts of the puzzle. We can't diagnose them, we can't help them unless we know what's really going on. And I think what I was saying about the research earlier in terms of involving patient community at all stages of research it's important for service development and policy as well. There's no point designing things that aren't going to help the people you're trying to help. I was saying earlier about kind of silencing and testimonial injustice. I think it's really apparent in the workplace as well. So I'm an HIV consultant, and my day-to-day job involves looking after patients on the ward with HIV, so often very sick patients with infections, and leading my team. And during COVID, so where I worked, we all got redeployed very early on. So we were put into new teams with people that we didn't know. We all wore scrubs, which was a change. And I remember how scared I was before the start. And I think lots of us felt like this just because it was a new infection. We didn't really know, what was going on, how to treat it. But also, I think the change in our routines and the people we worked with was very different. But for me particularly, I felt what probably exacerbated my feelings of imposter syndrome was that I was never recognised as being the consultant in the team. So it was a new ward, so that the staff there weren't familiar with me. They didn't automatically know I was the consultant, whereas on my ward they would have. And often when visiting teams came to give us advice, they would instantly assume that my registrar, who was a white man, taller than me, and I think that counts sometimes when you're wearing scrubs, I was never assumed to be the consultant. I always had to say, no, I'm the consultant here. And that's with me knowing that I'm used to inpatient work. I'm used to treating patients with very serious infections. That's what I do all the time. So that was an interesting experience to still feel that at this stage. And having been a consultant for almost 10 years, I still felt that. I don't think I was very surprised. I think I just expected that to happen. Having often walked onto wards and people assumed that I wasn't the consultant, but particularly in that case. But it is annoying because I think you have to work a bit harder to prove yourself as being the senior person that you are. And I think, again, when we think about inclusion in healthcare spaces, when we think about people of colour, for example, having to work twice as hard to prove themselves, I think it can lead to burnout. I think, it can lead to not feeling part of the team if you have to work harder to constantly prove yourself. It has happened to me even, before being a consultant, never assuming that I was the doctor on the ward, and that's from patients' families, from other staff members. I think if you're working in an area where everyone knows you and have worked with you before, then that's absolutely fine. You don't need to keep proving yourself. But when you're new, perhaps, you do feel that need, or you're made to feel that need. So I think that's why it was from previous experiences. I think it was an interesting thing about COVID wearing scrubs. I just think, although it's obviously important for infection control, I think it can really affect who looks like a doctor. So in terms of who looks like what you'd expect a professional to look like. And I think there's still so many stereotypes in medicine. So, people think that consultants are white men or surgeons are white men, and there's whole campaigns called I look like a surgeon, which is women on social media doing that, saying look, women can be surgeons too. So I think we still have an issue around stereotypes and what is deemed to be professional in healthcare, which we probably need to challenge more. I think that's a really important question. So I've been doing a lot of work around sexism and racism in healthcare for several years now. So before COVID, before people started talking about it more. But obviously when COVID came about and people started to notice that ethnic minorities were being disproportionately affected, there was a lot of discourse about racism, but also poverty. So social justice issues, essentially. And a lot of people were not necessarily getting things right at the beginning because the conversations were new, and perhaps it was people who didn't have much experience knowing about this stuff. So I started writing a few articles about it and found myself being much more vocal about things, particularly on social media, but in other ways as well. And I found myself feeling quite angry a lot of the time about what was happening in terms of policy to do with COVID, but also some of the discussion and the discourse. There was a lot of victim blaming that was going on, which I think can be an issue in healthcare. So this constant feeling of anger went on for quite a long time, and I really just thought, I can't live like this. The pandemic is not going to be short. It's unhealthy to feel this angry and this stressed all the time. So I think in the last couple of years, it's been really useful for me to disconnect. So actually disconnect and turn my phone off in terms of social media, but also just to make sure that I'm not always thinking about work. So really making sure I do things that I enjoy, making sure I'm talking to friends, making sure I'm not always looking at the news. Like, I think having that balance and making sure you do stuff that you enjoy and see people that you love. And it gives you the energy then to do the stuff that you want to do around social justice. And if you are, say, one of the few people in your role, then, it's great because you might inspire other people and you may get approached for mentoring or help with stuff, and it's really nice to be asked. It's nice to help more junior people, but it can be exhausting if you've got lots of people coming to see you because there's just less of you to do that work. I would say we need more than allies. We need people who are in solidarity. So the difference is that if you're in solidarity with someone, you understand that their problems are your own. So for example, when we think of structural racism, it's not that it only affects people of colour, it affects everyone in society because it causes issues for everybody. So understanding that structural racism is your problem as well, and advocating for that, for example, is really important. And as you say, it takes the work off people who are more directly affected. So I think, it's really important that we get everyone involved in this kind of work. I think if you see injustice and not think that someone else will do it, and yes, it's awkward, but it's awkward for everybody. So just to practice trying in some way to challenge it. And I've recently been on a course, active bystander course, which is being run more frequently in universities now, which talks about how if you see something happening, what you can do to try and challenge it. It may be that you don't feel that you can challenge it because there's an issue, but there's other things you can do to stop it happening. So for example, if you see something happening, you could ask the person if they're okay. So instead of challenging the person who's causing the problematic behaviour, you could just offer assistance to the person who's being affected. So there's different levels in which people can intervene, but I think it is important that people do that. They are active in their bystanding, essentially. So I think one is to remember why we're working in healthcare, and it is for our patients. So what can we do to improve their experience, their access to healthcare? And with that comes the whole thing about listening to them and validating what they say. So that's probably my main thing. So believing them. I think doing things that you're really interested in and meeting other people with similar interests, I think it just makes your working life more enjoyable. I think I'm still learning how to be the best clinician I can be. I think, one thing I didn't realise when I was a junior doctor was that consultants don't know everything, and they are always talking to their consultant colleagues and other people from the multidisciplinary team to get advice on certain situations. So one is to be a better clinician. I'm still learning to speak up, and I would like to be better at speaking up in meetings, and probably taking on more leadership roles. Like, I still feel like I'm quite shy, too shy to do those things. And some of it, for me to feel less of an imposter and more comfortable in my role, I always feel like I need to know and be prepared. So I would like to do more research in the future. So for me, having those research skills and being confident in them will help me do the research, because I feel, yes, I've got the right skills to do this. So it's really important for me to keep learning. So probably those are those 3 areas I'm concentrating on. So I've got 3 questions that I'd like the viewers to think about. So first of all, how can you use your voice to help others be better heard? Secondly, are you still learning? And if not, why not? And lastly, what do you love to do? And how do you think you can incorporate it into your everyday life?
Thank you for watching this Meaningful Conversations episode. We hope you enjoyed it. If you would like to see more videos in this series, then please like and subscribe to this channel and hit the bell so you can get notified of new videos as they're posted. We look forward to seeing you in the next one.